Right. Good afternoon and welcome to the Advanced CTR Clinical and Translational Seminar Series. This is a long-standing seminar series where the Advanced CTR brings together investigators to speak to us about their work and other topical issues around clinical and translational research. I have the pleasure of uh, you know, serving as the moderator for this seminar today. My name is Metotuli. I am chair of OBGYN, but for these purposes, I am the co-lead of the Professional Development Core of Advanced CTR. Today we have two talks. The first one I'll introduce shortly on alcohol use among young adults with ADHD, and then we'll have a second presentation to follow. The speaker for our first presentation is Dr. Amy Stamates. She's an associate professor and co-director of the Behavioral Science Ph.D. program at the University of Rhode Island. To introduce her a little further, she directs the Health and Alcohol-Related Problems Lab and the Simulated Bar Lab facility at the University of Rhode Island. She has 16 years experience, focused on factors that contribute to and exacerbate alcohol and other substance use and consequences among young adults. A primary area of research for the center is on understanding how impulsivity contributes to the etiology of problematic alcohol use among young adults, as well as various factors that may underlie or impact that relationship. Her research uses traditional lab-based methods, alcohol administration, and ecological momentary assessments to study these issues. She's well published with 76 peer-reviewed publications to her credit, focused on alcohol and drug use. She's currently the PI of a KO1 focused on the development of executive functioning and alcohol use disorder symptoms among college students with and without ADHD. She also is also MPI of an R21 examining the association between impulsivity, craving, and polysubstance use. So without much ado, let's welcome Dr. Stamates to give her talk on alcohol use processes among young adults with ADHD.
Thank you. Thank you for that warm introduction. I'm happy to be here. So today I'm going to be presenting some results from my K, which is focused on alcohol use among young adults, particularly with ADHD. So young adulthood is the age range between 18 and 25, and what we know about alcohol use during this developmental period is that heavy drinking rates peak during this time compared to other age ranges. We also know that alcohol-related consequences are prevalent, so things like injuries or physical assaults are highly reported in this age range. And 15% of young adults actually meet criteria for alcohol use disorder. And while most individuals might mature out of those drinking patterns after age 25, for some individuals, patterns of use may persist. So this represents a really important age range for interventions and for prevention work. A subgroup of young adults that are at greater risk are individuals with attention deficit hyperactivity disorder, or ADHD. ADHD is a DSM diagnosis characterized by hyperactivity, impulsivity, and/or inattention. Onset is typically in childhood, but it's a chronic condition and symptoms may last through adulthood. And studies that have examined alcohol use among individuals with ADHD indicate that these individuals experience more alcohol-related problems and they're at greater risk long-term for alcohol use disorder. But it's interesting because young adults with ADHD, studies have shown that they typically consume equal or less amounts of alcohol as compared to their non-ADHD peers. And so that's a little counterintuitive because when we think of alcohol-related risk or the development of alcohol use disorder, we think that individuals might engage in alcohol use more. They might be drinking more. But in this case, there are studies that don't indicate that. So that suggests that some other mechanism is at play here that could explain why they're at greater risk beyond just how much that they drink. One potential mechanism underlying their substance use could be related to dual process theories. So, dual process models suggest that there are two competing systems that determine behavior. The first is the controlled system. So these are slow, reflective, typically our executive functioning skills. And then our impulsive system is fast, reflexive, our reward system. And these two systems are constantly competing. And typically we see alcohol use disorder develop when the impulsive system dominates. Both systems have been implicated in ADHD. They're typically characterized by challenges in controlled and in impulsive systems. But most of the alcohol research that has been published is focused on executive functioning specifically. There's far less work conducted on alcohol-related rewards. In terms of the relationship between executive functioning and alcohol use, there is a wealth of research that has focused on executive functioning and how this is associated with alcohol-related outcomes. So use as well as the development of consequences. It varies depending on how executive functioning is defined, but typically what we see is that if there are challenges or deficits in executive functioning skills, that is associated with greater alcohol use among young adults in general, but also those with ADHD. And executive functioning is also hypothesized to have a reciprocal association with drinking. And so while there may be challenges related to executive functioning skills that predispose individuals to use alcohol. The greater alcohol involvement that happens because of alcohol's impact on the brain, those can also further impact executive functioning skills. So that's hypothesized, but there's really not a lot of research that actually studies that, especially in the young adulthood range. And certainly, a gap in the literature, the reason why I wrote my K is that it was unclear whether those with ADHD are more vulnerable for this pattern, given that they might already have deficits in executive functioning. So, executive functioning could impact how individuals regulate reward processes, particularly craving. Craving is a subjective state of urge to drink alcohol. Craving is a prominent reward process in most addiction theories and its criteria for alcohol use disorder. So that's why I focused on it in this work. Only a handful of studies have linked ADHD to craving. And in those studies, most of them are focused on other heavy substances like opioid use, or they're in severe samples, like participants that might be in an in-treatment facility. There have not been any studies conducted that have examined executive functioning and craving among those with ADHD, which is what the focus of my K was. Um, so the central question of my K was to understand whether young adults with ADHD are more vulnerable to the controlled impulsive imbalance that typically characterizes alcohol use disorder. And the goal is to be able to understand the etiology of these disorders because they're often comorbid together, and to identify intervention targets. And so for the study, I used a measurement burst design where I coupled lab measurements as well as ecological momentary assessment. And so participants came in 3 times over a 1 year period, so at baseline, 6 months, and 1 year. They completed a laboratory session followed by 17 days of ecological momentary assessment. And if you're unfamiliar with EMA, oh, wrong way. If you're unfamiliar with EMA, EMA is where we send surveys to individuals' phones throughout the day so that we can assess behaviors in one's environment close to the time that they're happening in real life. If you look on this slide to the right, you'll see this bar lab. This is my lab at URI's Kingston campus. And while this is a great space to collect alcohol use behaviors in a controlled setting, the reality is that alcohol use is influenced by a lot of things in one's environment, like their social setting, stressors, affect, things that happen in their daily life. And so really having an ecologically valid approach to understanding how these behaviors manifest for young adults is really important. And there's high flexibility in the design, so we're able to really understand how these processes might unfold in real time. There were three aims to my K. Today I'm going to focus on aim one just for the sake of time, and it's what I've analyzed so far. So the first aim was to understand how does its executive functioning measured in the lab relate to alcohol outcomes assessed in real life, and does that vary for individuals with and without ADHD? The second aim, which I won't cover today, but the larger goal is to understand whether these relationships, this reciprocal pattern between executive functioning and alcohol-related outcomes, how does that develop over a 1 year period for individuals with and without ADHD? And then the final goal of this project is to understand to identify event level predictors. So things like context and social setting. How are those predictors of alcohol related outcomes in real life for individuals with and without ADHD? So far in the study, we are in year 4 of 5. Participants, to participate in the study, they have to do an extensive screening process. They do an online survey as well as a phone screening. They have to be between 18 and 25 to participate. They have to report at least one heavy episodic drinking episode. So that's 4 or more drinks for women, 5 or more drinks for men in the past 2 weeks, and own a smartphone. Participants are excluded if they are currently in or seeking alcohol treatment. And to be in the ADHD group, they have to self-report an ADHD diagnosis as well as symptoms above a specific threshold. And this is confirmed by a diagnostic interview. To be in the non-ADHD or the control group, their symptoms of ADHD have to be below thresholds, and that's also confirmed with a diagnostic interview. So we screened over 700 individuals for this study. And you can see that 67 have actually completed the baseline laboratory session, which we will talk about more later in the discussion. So right now, who is in the study? It's mostly women. The mean age of the current sample is about 20. About 43% fall under the age of 21. They are about half junior class standing in college, and they're mostly white. The mean audit score, so audit is the alcohol use disorder identification test, is 10. And so anything above an 8 on this scale indicates hazardous drinking. So we would consider this an at-risk sample for alcohol use. Participants can earn up to $354 for completing the entire study. And just looking at baseline, the EMA component compliance is 90%, which is great. So participants, when they complete this study, again, they have a baseline 6-month and 12-month component to it. For each of these time points, they complete a laboratory session where they complete a battery of behavioral tasks. So they complete 9 executive functioning tasks that are computerized. And then they also do a self-report battery of their executive functioning, alcohol use, consequences, other substance use, and mental health symptoms. And then following that lab session, they complete 17 days of ecological momentary assessment where they get 5 reports sent to them each day across these time frames that you see here. At each report, they report on their craving for alcohol and for cannabis, their contacts, so where they are, who they're with, their peer setting, their substance use, and we also are collecting any medication use. For today's results, I'm just going to briefly talk about the measures that I analyzed. So we'll be looking at the self-reported executive functioning scores today. The behavioral measures are still being processed, and there's a lot of different scores to evaluate. So we measured self-reported executive functioning via the brief, so the behavior rating inventory of executive function scale. This has three indexes. The first is a behavior regulation index, which indicates an individual's ability to regulate and monitor their behavior. The cognitive regulation index is an individual's ability to control or manage their cognitive processes. And the emotion regulation index is an individual's ability to regulate their emotional response. And so higher scores on these scales indicate greater difficulties in these different areas. We're also going to look at consequences, so typical consequences that individuals experience as a result of their drinking. And to measure this, I use the Brief Young Adult Alcohol Consequences Scale. Higher scores on this indicate more consequences. And at the EMA level, we'll look at alcohol craving, so their urge in the moment, as well as their alcohol use, which is measured by the number of drinks that they consumed. So right now we are merging and cleaning the data still. For the EMA portion, I aggregated the scores across the first 17 days. So all analyses I'll be presenting today are at the between level. So how individuals vary from each other versus within a day. I use t-tests to explore group differences between the ADHD and non-ADHD group. And then I use regression models to examine how executive functioning was related to alcohol-related outcomes. So for our group differences, when I compared the ADHD to the non-ADHD group, the ADHD participants reported higher executive functioning difficulties across all of the brief subscales, which is what you see on the right bar graph. In addition, the ADHD group reported higher alcohol-related consequences compared to the non-ADHD group. So both of these findings are consistent with previous research. I did not find any differences between the ADHD and non-ADHD group on alcohol craving or alcohol use across the 17 days. In terms of the regression results, I'll present the non-ADHD group first and then the ADHD group results just for clarity. So for the non-ADHD participants, if we examine their craving and alcohol use across the 17 days, higher alcohol craving was related to more alcohol use during that EMA period, which isn't surprising. So if individuals were craving more alcohol, they tended to drink more if they were in the non-ADHD group. Interestingly, none of the executive functioning subscales were associated with any of the alcohol-related outcomes at baseline. So alcohol craving, use, or consequences. And for the ADHD group, we actually found the exact opposite. So for the ADHD participants, alcohol craving was not related to alcohol use during the 17-day period. So the opposite of the non-ADHD participants. And in terms of the executive functioning relationships, higher behavioral regulation scores were associated with more alcohol craving, but not use or consequences. So individuals who had more trouble regulating their behavior, particularly inhibiting or stopping their behavior, tended to experience more alcohol craving if they were in the ADHD group. So what does all this mean so far, these preliminary findings? Well, essentially, that mechanisms look different right away for individuals with and without ADHD. For the ADHD group, they experienced more consequences, but they didn't drink more or report greater craving than the non-ADHD group across a 17-day period. This suggests that potentially context could be driving experiences of consequences beyond how much someone drinks. So really looking at this in the momentary data will be critical. I did assess consequences at the momentary level, so understanding how those develop and what predictors of consequences in real time will be important. Interestingly, alcohol craving was not related to alcohol use during the 17-day period in this preliminary analysis, but it's important to note that this is at the between level. So I'm not examining right now the within day relationship. So how does craving in this moment or on this day impact actual alcohol use in this moment or on this day as well? And so that's a different kind of relationship that I haven't assessed yet, but that'll be my next step. Another potential another potential thing to consider is that the relationship could be contextually dependent. So affect could play a role here in whether craving actually results in alcohol use or some other contextual factor, um, like setting or something like that. So definitely areas to follow up on. And lastly, I mean, the executive functioning relationship with craving for the ADHD group provides support for the initial hypothesis provided by dual process theories. So individuals with ADHD who had more difficulties inhibiting or stopping their behavior tended to report more alcohol craving during that time, which is what we expected. So in doing this work, because it's a training grant, there's always lessons learned. And this was my first project actually recruiting individuals with ADHD. And so just some considerations if you're thinking about doing this work, or certainly an area that I'm going to consider in a follow-up project, is thinking about eligibility for the study. And so, individuals right now in this study, individuals are either being divided into two groups. Either they have ADHD or they don't. If they have a diagnosis and symptoms, right, via the diagnostic interview. But really, what we're finding in the screening process is that there is another group of individuals who meet symptom criteria, but they've gone undiagnosed. And there could be a lot of different reasons for that. They could be good at masking symptoms. They could be higher functioning, where they haven't had a lot of problems, where they've needed additional assistance. They could have less access to a primary care physician that could diagnose them. There could be a lot of different reasons for this, but really, I think not including them limits generalizability of the results because they do exist in the young adult population. So if I were to do this study again, I would have the third group to be able to understand this. Beyond that, I mean, we did collect level of symptoms, so we will be looking at the severity of symptoms and how that impacts things to further understand that. Another issue with this study that we've run into, and it's not just this one, it's really a lot of the work that we're doing on campus and other labs that are collecting college student data, is that student engagement is low. It's really challenging to get individuals into the laboratory to complete these sessions. And so if you're considering this, or again, if I do another project like this, I will recruit on campus, but also in the community just to increase participation. So next steps for this work is I'll be examining the contextual variables at the EMA level. There's a lot of data here to go through to understand how alcohol use manifests for individuals with ADHD. I still have to explore the baseline behavioral data for executive functioning. Again, it's 9 different tasks that they do, so a lot of different scores to see how those assessments are related to substance use for individuals, and then how they develop over time, which is the main goal of this study. So I want to acknowledge a few folks. I want to thank NIAAA for funding this work. I want to thank my K mentors, Lynn Stein, Lisa Wyatt, and Christy Jackson for supporting this project. the advanced CTR for helping develop the K. So Audra, Ulrika, and Sharon, who helped, provide a lot of feedback on the submission process. I want to thank my project coordinator, Anna Sherman. She's on the bottom right. I could not do this work without her. She really is an amazing coordinator and really has helped throughout this entire process. And I want to thank my amazing Harp Lab, all of my undergraduate research assistants and my graduate students, and who make research fun and this all a great process to be a part of.
Right.
Okay, thank you. Questions?
Thank you so much, Amy. This was
Yep.
a great presentation. Illustrates a lot of what we are trying to do here at Advanced CTR, support people, bright ideas like this to take them to funding and to do excellent work. So thank you. I have put a note in the chat that if you have any questions, you type them in there and I'll read them out while for us to address. While people are doing that, I wanted to ask the first question. Your sample that you showed was predominantly female. I wanted you to comment on whether alcohol use disorder or ADHD, I think data suggesting that maybe changing demographic. So comment on that and also the implications of that sample on your findings.
Yeah, so gender or sex differences with alcohol use and with ADHD are both relevant, right? So historically, alcohol use disorder has been higher among males, but in the last decade or so, we've seen a convergence in how females and males consume alcohol. So females are consuming alcohol at higher rates than previously, including binge rates. So they're drinking at heavy levels now than they did even a decade ago. And so while males might still have higher risk of alcohol use disorder, females have been trending upward. And so it's really important to understand their substance use as well. With ADHD, again, historically, males are typically diagnosed with ADHD more so than females. There's a lot of discussion about symptom presentation and childhood and how that might look. I think for this sample, we are at a point where we're really trying to recruit more males just to generalize the population. I think that that's going to be a main limitation if it stays this way, but it really reflects the college student population. We're collecting on campus, and it is primarily females, especially in psychology. So it makes it, recruitment's been a little challenging, but yeah, it's relevant for both of those disorders, and I think it will impact generalizability if we don't somehow get more males into the study.
Thank you so much. There's a question in the chat, and it reads, have you noticed a shift in socio-cognitive factors impacting young adults today, such as the rise of social media or digital impulsivity, and how these might be exacerbating the relationship between ADHD and problematic alcohol use compared to, say, a decade ago?
Yeah, I mean, I think there's a lot of implications for social media. I think it depends on what there's a couple areas that I'm thinking about, and feel free to clarify. So social media depicting normative behavior. So if individuals are posting pictures or online posts of substance use, that makes it more normative to engage in. So there's some literature on that suggesting among adolescents and young adults, if they are seeing more alcohol-related images on their social media, that is predictive of their own alcohol use. So norms are relevant. Um, in terms of another area I was sort of thinking about is just increased social media, if that is related to sort of mental health symptoms like depression or anxiety, and those are certainly associated with increased substance use. In terms of the really exacerbating the relationship with the ADHD, that's an interesting question. I don't know if there I'm not sure if there's any literature focused on social media among individuals with ADHD, but like I said, there's other mental health symptoms that again overlap with ADHD. So it certainly could be relevant. I'm just not as familiar with that area of work if it's been done.
Thank you so much. I'll ask the last question and we'll move on to the next talk. What's
Okay.
next for this project?
I have one more year, so we're trying to wrap up the follow-ups. So there's that part. I will spend this summer mining the data and really analyzing all those future directions that I talked about. Um, some next year, I really need to start developing the R01 for this project. I think an extension of it will be to look at other outcomes related to substance use. I think driving related risk is really important for individuals with ADHD. So that will probably be a main focus given this project and other studies that we do in my lab.
Thank you so much. Outstanding presentation and
Yep.
discussion. So thank you so much for doing this.
Thank you.
All right, so we'll move on to the next presentation for the sake of time. The next presentation is by Dr. Justin Berk, who is an associate professor of medicine and pediatrics at the Rhode Medical School of Brown University. He's also the director of the Center for Health and Justice Transformation at Brown University Health. The topic today by Justin will be on advancing justice through health, implementing novel treatments in carceral settings. A little more about Dr. Berk. He's triply boarded in internal medicine, pediatrics, and addiction medicine. He previously served as a medical director of the Rhode Island Department of Corrections, where he oversaw healthcare delivery for one of the nation's largest state prison populations. Dr. Berk's research applies clinical and translational methods to one of medicine's most underserved settings, jails and prisons. His work focuses on hepatitis C treatment, medication for opioid use disorder, and health equity for justice-involved populations. I'm really excited for us to hear this presentation. Of note, this was recorded because Dr. Berk is out of town today. But let's watch this intriguing lecture.
Hi, thank you so much for coming. I'm sorry I can't be there today, but very excited to talk about something very dear to my heart, something I'm very passionate about: advancing justice through health, implementing novel treatments in carceral settings, which is going to be a brief kind of discussion about some of the work that I'm doing in trying to apply implementation science to increase evidence-based interventions in settings that often go unnoticed for marginalized populations, specifically jail and prisons. I'm an addiction medicine physician who spent a lot of time working in the jails and prisons in the Rhode Island Department of Corrections. I was a former medical director there and still continue to provide some addiction care for people who are incarcerated, and doing some providing care for people who are formerly incarcerated and coming out of jail and prison. I really want to start by really kind of just framing how I got into correctional medicine, and that's really through addiction and the opioid overdose crisis. The opioid overdose crisis, as many people here know, is one of the most unprecedented public health crises that we've faced. When I was going through medical school and training, people talked a lot about the HIV epidemic and had all these war stories of when HIV first came out and people were dying left and right of AIDS. And this was really, something that has dramatically affected the medical system. But there was a New York Times article a couple of years ago that really kind of put the opioid overdose crisis in perspective with a lot of these other crises we talk about, where peak HIV deaths were closer to 50,000, and now we've had over 100,000 deaths annually for people having drug overdoses. And so, not to compare crises, this is something that is really the major public health disaster of our time outside of COVID. And so it's really something that people want to, try to address. And this opioid overdose crisis is a medical condition. There's really robust evidence that there are neurological objective findings of the disease of addiction. This is considered the addiction disease brain model, where we know that fMRI imaging shows very significant semi-permanent changes to the brain for people who are chronically using drugs, whether they're opioids, alcohol, methamphetamines. neurotransmitters, specifically dopamine, are dramatically shifted for people who are using drugs. There's brain inflammation patterns on autopsy where people can be identified by chronic drug use. These are all changes in the brain mechanics. And perhaps most importantly, the role that molecular genetics plays really demonstrates an objective finding of the disease of addiction, in that the number one risk factor for someone to develop opioid use disorder or substance use disorder, alcohol use disorder, is the genetics they're born with. It's not a moral failing. It's not specifically just behavioral processes. There is objective components. And there's this beautiful review article from the New England Journal of Medicine from Nora Bolkow, who's the director of NIDA, the National Institute of Drug Abuse, who really highlighted this. She's a major leader in this field. And it really does kind of lay out this process of thinking of disease as a brain model, through a brain model. But we don't treat the addiction as a disease. We very much criminalize this process. We don't treat it with a medical standpoint. We treat it with incarceration, with law enforcement, with putting people behind bars to try to overcome this opioid overdose epidemic, and that doesn't work. I'll note that incarceration has a disproportionate impact on marginalized populations. So for a lot of people here that work in the field of health equity, whether it's a racial inequity, a disparity among people who are indigenous populations, LGBTQ, based on ability, all of these individuals are disproportionately impacted by incarceration. They're incarcerated at higher rates than non-marginalized groups. And so again, if we what I'm leading towards is, if we are wanting to talk about how to address health equity in society, if we want to talk about how to address the opioid overdose in society, if we want to talk about how do we approach a lot of these health disparities, looking towards the criminal legal system is really a major critical touch point for doing this type of work. In fact, most people who have addiction ultimately do go on to become incarcerated. Over 75% of people using heroin have some criminal justice involvement. Over a third of people that have diagnosed opioid use disorder have encountered the criminal justice system within the past year. We talk about the natural progression of disease in diabetes leading to, a foot amputation or heart disease or kidney disease. The natural progression of disease of hypertension might be a heart attack or stroke. The unfortunate truth is the incarceration of the natural progression of disease of addiction is incarceration, is finding yourself in a jail or prison. And incarceration dramatically increases your likelihood of dying from an opioid overdose. A very canonical study that is now getting old, but basically showed that within 2 weeks of release from a prison setting, individuals are nearly 130 times more likely to die of opioid overdose. This is one of the highest risk periods for opioid overdose in any care continuum of a person's life. And because of this, a large majority of people who die of overdose are people who were recently released from a jail or prison. Now, going back to this medical model, though, we know that treatment, medications for opioid use disorders, can save lives. If you treat people for addiction while they're incarcerated, the risk of overdose death has been shown to decrease by up to 80%, which is as close to a miracle drug as we have in the field of medicine. No other medicine we prescribe, be it metformin or amlodipine or fluoxetine, has any type of mortality benefit as buprenorphine and methadone for opioid use disorder. And so I bring all this because it really does show that there are evidence-based interventions to treat a known medical issue, and that jails and prisons are a unique setting where their uptake is very important. Now, to summarize this, incarceration is a natural progression of a disease. Incarceration risks overdose and causes harm. Medications for opioid use disorder saves lives when brought into jails and prisons. And we don't go into this too much, but there's actually a right to healthcare in jails and prisons based on ADA law and constitutional law, where a fun fact is that people who are incarcerated are the only population that have been deemed to have a constitutional right to healthcare. This comes from a Supreme Court Act, Estelle v. Gamble, saying that deliberately, indifferently ignoring an incarcerated person's health issues is a form of cruel and unusual punishment and violates the Eighth Amendment of the Constitution. So based on all this data, one would think This is low-hanging, easy interventions. This is where incarcerated individuals clearly all have a right to access to MOUD. Evidence-based intervention should be widely available, right? And that's not the case. In fact, some of the research we've done has looked at what jails and prisons do offer medications for opioid use disorder. And the long story short is most facilities do not offer buprenorphine or methadone. In fact, if you are on these life-saving medications when you are arrested, you are often forced to come off the medications, which can make you quite sick. And whether it's a jail or a prison, there's some slight differences, but both of them, the vast majority of facilities do not offer this evidence-based life-saving treatment. And so this is where a lot of my research tries to focus on. Why is this that prisons and jails don't provide life-saving evidence-based interventions? And there's a few different rationales, but a lot of it comes into this field of implementation science of looking at the contextual determinants. What are the facilitators and barriers? And ultimately, there's a lot of barriers that create this delay in uptake of evidence-based interventions in prisons and jails. Implementation scientists often talk about the 7 to 10 years that it might take from research to go into practice. There's a delay, or what we call the prison penalty, that delays that uptake by even more years as evidence-based interventions become needing to adapt into this new setting. And for medications for opioid use disorder in general, we found that there are some clear logistical barriers in bringing this treatment to jails and prisons. One is that there's just logistical challenges, staff oversight of medication administration, where a correctional officer and a nurse often has to administer the medication, but then a correctional officer also watches to make sure that the medication is dissolved or completely swallowed so that it's not diverted, it's not spit up and then used for trade, creating safety concerns or diversion at the bottom. And then there is a lot of stigma with medications for opioid use disorder, especially receiving them in a jail or prison where it's often very obvious that you're receiving these medications, and therefore it's very obvious that you have a diagnosis of addiction. And so harassment can come from certainly correctional officers, but also peers, other people who are in the jail or prison, nurses. Not everyone has buy-in for these medications. And so there is overwhelming stigma really at all levels, from patients to administrators administering this medication. This is a photo, a stock image. It's used with permission of what a typical medication for opioid use disorder line might look like, because buprenorphine specifically is commonly taken as a sublingual film and has to dissolve. A nurse provides the medication and then watches with a correctional officer as individuals must sit with their hands in their pockets or sitting on their hands, letting the medication dissolve. And then when they are finished taking the medication, they raise their hand, will have a flashlight mouth check, have crackers and water, and have to show that there's no medication left in their mouth so that they're not going to take it out with them. And we did some qualitative work with a range of relevant parties, including incarcerated people, including medical individuals, including correctional officers and wardens, to kind of ask about some of these barriers and some of these facilitators for medications in a jail and prison setting. And one thing that is a unique finding that we've written about is that the addiction treatments actually create safer environments, and that often if you treat addiction like a medical issue, people tend to be less upset. They're less in withdrawal. They're not sick. They're not vomiting. They're not frustrated. They're not having a lot of cravings. They're not seeking other drugs. They're not trying to buy or bring in drugs or contraband. And so by offering medication, it creates a lot of supports for these correctional officers and leaders. And this is some of the preliminary data that is really geared towards having a good understanding of buy-in from the people who are the ones doing the program. It's not just a public health reason to have medications for opioid use disorder in jails and prisons, but that there's benefits to facility culture and safety. And this type of work can get buy-in from the other types of people who are actually administering the program. Interestingly, there's also a lot of evidence that patients really value having input for their treatment selection. And this makes sense, I think, in a jail and prison where autonomy is essentially taken away from most individuals. Having the option to have a choice is something that has a high preference for patients. And in other literature, this has actually been shown to increase treatment adherence. The best medication is the one that you're going to take. If it's a medication you want to be on, you're more likely to take it. And if you're taking your medication, the outcomes are going to be better. And so for these reasons, patient preference is actually quite important. And then people brought up this concept of a relatively newer medication formulation, which is injectable treatment. Buprenorphine comes in a monthly shot now, and people discussed how it led to privacy, where they're not having to go through the buprenorphine med line and sit on their hands and have someone check their mouth every day. You can do it in a nursing visit, so no one else will know that you're necessarily receiving this medication. And it's very convenient because you're not having to go and take this medication on a daily basis. You can do your monthly shot and then go about your day-to-day. And so this injectable buprenorphine is something that we've continued to explore because it is a possible solution addressing some of these barriers that underlie implementation. Because it's logistics, you can do this with a medical team without additional correctional officer surveillance. There's private administration, which can address some of the stigma. And it's essentially impossible to divert or cheat or sell or anything like that. Perhaps most importantly, there's a component of effectiveness that actually may be really beneficial for people who are leaving jail and prison and going into that really high-risk period after jail and prison where opioid overdose deaths are highest. Having the injectable provided allows the medication to stay in your system during this really high-risk time after release. So that if you're released on Monday, you're not having to try to find your doctor on Tuesday to get a refill on medications, but you have some time to try to address the things that are most important to you, your family, your job, your living situation. And if you do fall off the wagon, you have buprenorphine on board, which dramatically helps reduce overdose and also dramatically helps reduce cravings for likelihood of returning to use. We wrote about this in the Journal of Addiction Medicine and tried to lay out the arguments for offering this type of medication as a way to overcome some of the barriers for MOUD implementation in jails and prison settings. We also have some really insightful quotes that I won't read to you entirely, but just again, correctional officers saying your facility is going to be safer. There's a decrease in violence associated with treatment, and incarcerated individuals themselves saying, you know, now that I have medication, I'm not getting booked. I'm not in SAG or solitary confinement. I'm not bringing drugs into the institution. Their addiction is being treated, and so they're much more functional and doing quite well. And so this has now led some of our qualitative work to then test the theory using a clinical trial that incorporates a lot of implementation science frameworks and ideas. One is a novel methodology that we're really excited about called a partially randomized preference trial that essentially is a RCT, but if you have a strong preference for treatment A over treatment B, you can state that preference. You can be in the preference cohort where you are receiving that medication and your strength of preference is controlled for in data analysis. And if you're ambivalent, if you don't have a strong preference, then there's a randomized arm where you then are randomized to treatment A versus treatment B, in this case, 2 forms of injectable buprenorphine. And so it allows for patient choice, it controls for preference bias, and actually as a methodology offers a lot of really great benefits in doing research in marginalized populations and supporting health equity. This is also a hybrid trial where we're looking not just at the effectiveness, but really understanding the implementation of the unique environment, because this is one of our goals, is increasing uptake of evidence-based interventions in jails and prisons, understanding how this is feasible, how it's acceptable, and how it can be done. Ultimately, the goal is to optimize treatment of medications for opioid use disorder, but one of the things that has come up that may be of interest to some is really optimizing options. So not just saying that injectable is the way to go and overcomes, any other treatment option. We should just force individuals to have this injectable because then you don't have to worry about stigma and logistics. No, we very much have done a lot of community engaged work to really highlight the importance of patient preference, again, not just in supporting autonomy of a marginalized group, but ensuring people are able to stay on the treatment that they want. That's going to increase their likelihood of treatment adherence. That's going to increase their likelihood of increased uptake, and that's going to ultimately improve outcomes from a health standpoint. I'll briefly talk about another study that is really building on this. If we've talked about kind of addressing opioid use disorder, there's another disease process, hepatitis C virus, that's very prevalent in jails and prisons. And it's again, another critical touch point of a public health opportunity to treat people that have hepatitis C. There's 2 studies that came out in the past 5 to 10 years that really look at low barrier treatment of hepatitis C treatment. There's a MinMon or minimal monitoring model that basically says if you just give people hepatitis C medicines and then send them on their way, they do quite well. Hep C medications now can treat and cure within 8 to 12 weeks, which is not the previous standard. Medications often had many more side effects and required very long treatment courses. Now in 2 or 3 months, you can completely cure someone from this chronic disease of hepatitis C. And another study, HERO, showed that basically providing these medications, even to people who are actively using drugs, can also be very effective. And so building on this new data that says, you don't have to follow these patients closely. This new data that says, even if people are actively using drugs, they can still take this medication. Jails seem like an opportune time to find people who are testing positive for hepatitis C and help initiate treatment. Now, one of the major barriers in a jail is that the length of stay is very uncertain. It's often short stays. The average length of stay the median length of stay can be anywhere between 3 and 5 days. And it's really uncertain if you're going to get out next Tuesday or in 6 months. Because in jail, you are awaiting trial. You have not yet been found guilty. You have not yet gone in front of a judge who says if you can be out on bail. There's a lot of complications that makes it very difficult to predict how long you're going to be in jail, meaning it's very difficult to predict, will you be here for 8 to 12 weeks to complete treatment? But because these treatments are so effective, they're so highly tolerated, there's low resistance, and that giving all the medications up front works, new data suggests that maybe we can do this. And so this is something that we implemented in the Rhode Island Department of Corrections. We're the first jail to really implement low barrier Hep C treatment in a jail setting and then write about it, and basically showed an 85% cure rate, which is the same as what you would see in the community, which is really excellent and really promising. But there was significant loss to follow-up, which we've now put into, we're now engaged in an R34 trial using community health workers and other community supports to try to reduce loss to follow-up and prospectively assess implementation of low-barrier Hep C treatment in jails. I'm very grateful for a lot of the bridge and implementation science and advanced CTR people who have been supportive of this. Hep C and opioid use disorder are just 2 examples. Really, correctional health is public health. This is a setting that is known to be where COVID-19 has spread, where hospitalizations frequently occur. Measles outbreaks are now occurring in detention facilities. It affects nursing home care, antibiotic stewardship. All of the public health goals that we're kind of all trying to address very much are impacted by the correctional healthcare system. And so again, this is really a ripe environment for implementation science to understand how to bring more evidence-based interventions into the field of correctional health. I think importantly, to emphasize, incarcerated individuals are very rarely brought into the discussions about what interventions are needed, how research can be done. And I'm always grateful to learn from other implementation scientists here, talking about how that's really a core part of implementation is community engagement. And so I think this also kind of demands more infrastructure and investment in trying to bring in people who are incarcerated and formerly incarcerated to help lead the future of some of this work. I really got into some of this correctional healthcare work through addiction, but also a very formative class in college, actually, on Dostoevsky. And there's a quote that's commonly attributed to Dostoevsky that says, the degree of a civilization and society can be judged by entering its prisons. And I think really shows that the way we treat people who are often marginalized by society is a marker of who we are as a society. And so getting the privilege to care for people who are often overlooked in jails and prisons is something that I'm really grateful to get to do here, and grateful for all the different people who have gotten to support that. I've had a lot of great mentors and collaborators. My K-23 mentorship team, Dr. Rich, Dr. Konis Mitchell, Dr. Lee at NYU, and Dr. Brittany Rubenstein at Duke. The advanced CTR group, specifically Dr. Rounds, Dr. Van Morton, Dr. Irvin, they have been really wonderful mentors and supporters. I have lots of research and collaborators here at Brown that have been really, really outstanding, both from a qualitative implementation science and ID standpoint. And I have a very lovely wife and two wonderful, adorable twin children that I am also very, very thankful for. And so with that, unfortunately, I'm not here to take questions, but thank you for attending. There's a survey to follow, and on May 14th, don't miss pregnancy and lifelong health, a very important topic too. Thank you for allowing me to be here, and I hope the rest of the day goes well. Thank you.
Thank you so much, everyone, for jumping on. I apologize again for the technical difficulty
Thank you so much.
with the sound, but I'm glad you stuck with it to listen. And as already said, we have an upcoming talk, Pregnancy and Lifelong Health, which is coming on next month. So hope to see you there. Thank you so much.